Uh, just wanted to introduce myself for those of you that I haven't had the pleasure of meeting before. I'm Dr. Edgar Villarreal, here a psychologist in Denver, Colorado. I'm also your chair-elect for the VA section of Division 18. Dr. Uwamaza apologizes she's not able to join us here today, but we've got a really good speaker lined up, and he's actually our very own Division 18 webinar coordinator. So here today we're joined by Dr. Jeremy Saenz, who I believe is a psychologist at the Texas Valley Coastal Bend system, and he holds a Ph.D. in psychology from Texas A&M University. And Dr. Saenz has been known for creating outreach events and trainings that are focused on the LGBTQ plus affirmative care community, and as well as creating other groups for individuals that identify as part of the LGBTQ plus community. So today he's going to talk to us about transgender and gender non-binary, queer plus veteran affirming care. So Jeremy, thank you so much for joining us. We'll definitely be interested in the topic that you have lined up for us. And again, I'll monitor the chat and I'll pause you in between if there's any questions, but I'm going to turn it over to you now.
Wonderful. Thank you so much for the introduction. So this is one of the topics that I really do find myself passionate about talking to people about or training them in. If there are any questions, I'll have a hard time seeing the chat, but Dr. Villarreal will let me know if there are any questions. And if we don't have enough time for them, you can always feel free to reach out to me. So just to kind of go into what I'm presenting again, I'll be using TGNQ plus as kind of the acronym that we're talking about for today's topic. And that stands for transgender, gender non-conforming, gender non-binary, gender queer, queer plus, which is a little bit different from LGBTQ plus, more specific, or looking at gender diversity. Now, as far as our learning objectives go, I'm going to be identifying TGNQ plus definitions and terminology for y'all, conceptualize identity development and its impact on TGNQ plus veterans, conceptualize how DoD culture and policies may have impacted TGNQ plus veterans, and utilize guidelines, evidence-based strategies to create change with TGNQ plus veterans, as well as our last learning objective, which is going to be to identify how to provide TGNQ plus affirmative care. Now, I already went over a little bit about these differences, but LGBTQ plus is kind of the broad spectrum, including different populations: lesbian, gay, bisexual, transgender, queer plus, other sexual minority, transgender and gender nonconforming identities, whereas TGNQ plus incorporates a little bit more of the gender diversity spectrum specifically. And there's a lot of different acronyms out there. Again, specifically, I'll be using TGNQ plus, but I'll also be talking a little bit about sexual orientation. Now, when we think about this a little bit, we want to think about these acronyms as not including everyone when we say them. Each individual identity may include a different culture to it. So, for example, with lesbian, gay culture, they may be a little bit different. Transgender, gender non-binary, they may be a little bit different. So we want to think about it and how it affects the individual. Now, that also being said, when we're talking about TGNQ plus populations, some people, may not meet criteria for gender dysphoria when we're talking about this. Remember, it's an identity. We're not thinking about it as being a problem or there being some sort of mental health diagnoses always attached to it. Now, sometimes I get questions about queer. And the word queer is a reclaimed word, and it can be used not only for reference to sexual orientation as an identity, but also as reference to gender identities. And there's a little bit of a cultural difference. Some older cohorts may find that as an offensive term, and younger cohorts may not. And that's Sometimes even with older cohorts, some people have accepted or adopted the term and some people have not. So it's important to think about your audience and how they think about the word queer when we're using it. Now, when we're talking about gender affirmative healthcare, sometimes also known as gender responsive healthcare, when we're actually putting things into action. So this is the provision of healthcare services to include medical, behavioral, and surgical services that is done in an inclusive, sensitive, and affirming and responsive manner. With this, we're thinking about how culture impacts things, what may be preventing people from engaging in certain healthcare modalities, as well as trying to get their input in how to better services is one way of also looking at this. Some of y'all may have also heard of the term dead name. Some of y'all may not. So a dead name is where someone's, say for example, birth name has been changed and they no longer use that. And dead naming is just the verb of that. So for example, if my name at birth was, Jeremy, and now I'm going by, let's say, Alice or Rosalie, using my name, Jeremy, would be dead naming. The other thing that we want to look at is minority stress. So minority stress, and you all may have heard minority stress models or minority stress theory. This is really important when we're thinking about what may be going on for people in the TGNQ plus community as well, and more specifically in regard to this presentation, veterans who identify within the TGNQ plus populations. Now, this is minority identity related experience of often frequent overt and covert discrimination. For example, homophobia, transphobia, biphobia, heterosexism, and racism that subsequently affects your quality of life and health. And I'll show you what this looks like in practice, a little bit of a model of how things can impact. One thing I want to highlight is that, oftentimes we may not see things overtly, but it's the covert part that often causes a lot of damage, especially with when it goes unnoticed by some people, or sometimes is that question of, did that actually happen? Or is that the reason why I didn't get these services? And of course, overt, it's a little bit easier to identify with, but we'll talk about that in just a few minutes. Now, I've wanted to make sure that we also know what sex assigned at birth is, or assigned sex at birth. And this is literally the sex that was assigned to you at birth, but this is based on your genitalia. And this often doesn't have anything to do with looking at chromosomes like X and Y. And when we think about sex, there's male, female, and intersex. Now, when we think about gender, and gender is more of a construct, there's many different gender identities, and this is how an individual identifies with themselves in regards to gender, regardless of their sex. So examples can include female, male, genderqueer, gender non-binary, or other genders, and there can be many different gender identities. Now, gender expression is a little bit different. So gender expression is how we express our gender identity. Maybe it's a little bit more on the feminine spectrum, or masculine spectrum, or other. When we think about sexual orientation, this is also different. So this is in regards to your physical or emotional attraction to an individual or towards another individual. And some examples of this can include, attraction to men, women, or other genders. And for identities, some people may label this as lesbian, gay, pansexual, queer, heterosexual, or straight. That being said, not everyone identifies within identities that have labels. And I think I've seen that a little bit more commonly with newer and newer generations. And that doesn't always mean that they haven't accepted who they are or who they're attracted to. That just may mean that they don't identify with a label. Now, as far as disparities in cultural competence go, so I may have mentioned covert discrimination a little bit earlier, but unintentional or covert discrimination and or stigma has its impacts. So sends negative messages about your identity or who you may identify as. It may facilitate miscommunication, misdiagnosis, overpathology, and misinformed treatment. So when we may have stigma against identities that we're not aware of, this can cause a lot of harm, and this can sometimes result in treatment non-adherence because someone's not understanding you, they may not trust you. This again results in distrust of health providers, and if you've had negative experiences before, you're less likely to want to seek help because you may not want to go through that again. And unfortunately, that can lead to unmet healthcare needs and higher rates of health disparities. Now, when we think about military demographics, there is about an estimated 15,500 active duty service members and Guard Reserve members. And, this is with, a study with Gates 2014, estimated 134,300 transgender veterans. So we have quite, a number of people that, we are serving or may be serving that we want to consider about, their experiences. And within another study, and this is maybe in 2014, now 40% of new cases of gender identity disorder were found 2 years after 2011 VHA directive. Now, I want to be very clear that gender identity disorder does not mean that you may identify as transgender. You can, again, be within that community or that umbrella term and not experience gender identity disorder. And there was a lot of problems with that diagnosis in general that got changed. And there's even further push for even gender dysphoria disorder or dysphoria to be changed in the DSM. Now, when we think a little about this a little bit more, or divide it a little bit more, in 2015, there was a health report by RAND indicating a percentage of transgender service members is equivalent to what is seen in civilians. The one thing I want to kind of highlight with some of these studies is, much like many of you probably know or have thought of, we want to think about who is likely to report with this. And sometimes there is a fear of reporting your identity. You may not know your identity yet or come to terms with it, that often sometimes affects some of these numbers when we are doing some of these studies and collecting data. And sometimes there's a fear of being found out and what that means. Even if you've been told that this is anonymous, et cetera, there can still be kind of that anxiety there for many historical reasons where entities have caused harm or other people have caused harm. Now, when we're talking about minority stress and health disparities, the impact of stigma, discrimination, and minority stress impacts your health disparities. So think about all the compiled stress of not only having, say, a mental health problem or depression, anxiety, et cetera, but also having to think about, will I get discriminated against? Was what they said, the provider, something that I'm mistaking as discrimination, or wasn't it discrimination? Is it something that maybe I'm overthinking? Is it something that I'm not overthinking? Those kind of questions pop up. And this is a part of minority stress, thinking about, was that action something that was maybe problematic? Or am I maybe often have a fear sometimes of not being handled, or your case or your presentation or even yourself being respected? Again, that's going to be a potential barrier in your ability to want to seek care. And when things often go untreated, that's where they can start to compound in many different ways. Now, that also being said, sometimes people are afraid of disclosing, even when we tell them reasons why it may be helpful. And again, that's going to impact the reason why you want, or the reason that you're going to seek care. And sometimes the reasons we want to know about identities is because it can affect your healthcare, what we need to look out for, or even cultural things that we want to think about that may inform your care. Unfortunately, sometimes when things are not overtly supportive, there can be that barrier to reporting, like I mentioned. Now, this is kind of a visual way of looking at things, but if you were to feel depressed and let's say you were denied or received poor health care, maybe with the poor health care, it's that they glossed over how things may be impacting you related to stigma or discrimination. Maybe it's laws that were passed in your state, like bathroom bills and how that's affecting your depression that's not being taken into account or ignored. Um, this may start to compound and you may start to experience inability or affected work performance. And let's say it started to get really bad because you're not receiving the care that you need or receiving any care at all. This may cause a potential loss of job if it gets really serious and benefits. And unfortunately, that can cause a loss of resources or for care and further depression. In general, some studies have indicated that veterans identifying within LGBTQ plus community anticipate discrimination. And this is really unfortunate because, again, this can be one of those barriers that prevent our veterans from seeking care. There's higher rates of some health and mental health problems compared to general populations. And, you know, impacts of discrimination, whether they be systematic, organizational, familial, peer, interpersonal, need to be considered when we're thinking about how people within TGNQ plus populations, specifically again TGNQ plus veterans, may be impacted by these things, and how we can, as mental health providers, start to help people to overcome them or maybe even change systems. This is yet another example. Let's say someone received covert or overt discrimination with a healthcare provider. They're decreased healthcare, or they're not as likely to seek care, or maybe they even receive psychological or emotional harm from this visit. So increased likelihood of poor physical and mental health needs not being met, and this may lead to decreased productivity at work, loss of job, depression, inability to find or pay for healthcare services, and increased problems with depression. Now, this is not true of everyone, but this is just an example of how a health disparity with these populations can look like. When we think about military policy and history, this is one of the things that may be impacting people and their trust when it comes to healthcare, the messages they receive from laws. And this is true of many different people who identify in different ways, is that when a law is made that tells you something about your identity and often gives you a message about whether, it's accepted, if there's stigma against it, etc. And bathroom bills are one way of, getting covert messages. And unfortunately, it's not positive, and it's very unfair and unjust. In regard to military policy, there was a number of things that happened, and this is kind of a brief synopsis, so forgive me if it's not too detailed. We have an hour to present this, so one of the first ones was Don't Ask, Don't Tell in 1993 to 2011. And this is not to say that there was not stigma before. In fact, it may have been a lot more harsh, but with this Don't Ask, Don't Tell, sexual minority veterans allowed to serve in secret. TGNQ plus were not covered in the repeal. Enlistment questions eliminated, discharge often not honorable if discovered, asking not always, people asking were not always discharged. Unfortunately, sometimes I think the term that I've heard people use, especially other veterans, is kind of thinking about it like a witch hunt. And you can imagine how that impacts, the level of anxiety and sometimes even depression that people felt, and the need to feel kind of on guard to protect themselves and their livelihood. And, this could also result in different kinds of harm, emotional and psychological definitely being one, but sometimes even physical for some folk. Now, that being said, in June 2016, veterans that were open about their identity within the transgender TGNQ plus community were able to serve. No open transgender veterans were able to serve previously. Now, in August 2017, no open transgender veterans were able to enlist. Then in 2017 of August, open transgender veterans were able to continue service. There was a study being conducted. Now in 2019, there was the transgender military ban, which many of us are familiar with. And I want you, as I'm kind of talking about these different dates and what happened, I really want you to visualize and think to yourself, how is this impacting people and what messages are veterans getting about this and people wanting to enlist and kind of just even the general TGNQ plus population getting as they're kind of being told these different things with these different laws. And there are messages that people are receiving about this, and unfortunately that can feed stigma. Now, things changed April 2019 to January 2021. Veterans were allowed to enlist with a gender assigned at birth, but could not medically transition. And then in January 2021, the restrictions were lifted. Again, I really want you to take home that there are messages being given by this, and you can see when things are allowed and then taken away, how that may start to create a culture of distrust or messages of distrust, and trying to keep them, or people trying to keep themselves safe in who they tell and when they do. Now, when we're thinking about the military and military culture, it provides an opportunity to belong. There's a sense of duty. There's structure. There's more often spoken about a culture of masculinity, as well as cultural messages about emotion expression. And what I mean by that is, when we express emotion, what is validated as being like, okay, this is appropriate to express, and what is not okay to express. And sometimes that's the vulnerable emotions that are sometimes covertly said to not be as appropriate. Not that anyone is actively saying that, and they may, but this is something that I found frequently when working with veterans is often talked about. Now, when we're thinking about teaching, well, actually, I'm going to pause for a second. Do we have any questions so far?
Not on the chat, but we can pause here real quick if anybody wants to drop a question in the chat for Jeremy. If not, we'll continue. Not seeing any. So if you want to continue, I'll let you know.
All right, sounds good. So when we think about TGNQ plus affirmative care, we want to think about knowledge. And so this is really understanding the effects of stigma. Much like I mentioned to you before, it's important thinking about what messages we receive from policies, what messages we receive from organizations. Do organizations validate having pronouns displayed, or having TGNQ plus, LGBTQ plus, LGBTQ plus flags present to show affirmation? Are even interviews structured in a way that inform affirmative or responsive care? So these are things that we want to think about that may be presenting barriers to people's willingness to come to go past session 1 of an intake, or even come to, say, a health organization in general to seek help. And I will tell you, one of the things that I frequently hear and even see in research is that having insignia that show that you're affirming really makes all the difference, even on websites, because people often seek that to make sure that it's safe. It's at least one reassure that, hey, this may be okay, because they're willing to put this up. Now, another thing that's important is understanding that being TGNQ plus or being in LGBTQ plus populations is not a psychological disorder. And understanding that same-sex attractions, as well as gender diverse identities, are normal. Now, how you use your knowledge and attitudes impact the treatment that you give, and understanding that unique experiences of individuals who are, say, for example, bisexual, pansexual, and I told you I was going to talk a little bit about this because TGNQ plus is just referring to gender diversity or transgender, gender non-binary, gender non-conforming, gender queer, queer plus communities. But there's also sexual orientation. People are more than one identity oftentimes. And with bisexual people or pansexual people, there's often different impacts as far as healthcare concerns go. So if we look at it compared to, say, outcomes for other populations in the acronym of LGBTQ+, you're going to have different rates of, say, mental health problems, different rates of health disparities, and that's an impact of stigma. Now, that also being said, understanding the difference between sexual orientation and gender identity are important. So people who identify within the TGNQ plus communities doesn't mean that they identify as, lesbian, gay, bisexual, pansexual. They may identify as heterosexual or straight. Be knowledgeable about and respect importance of relationships and support systems in LGBTQ plus populations. And what I mean by this is that some people may not have the families that they were born into, but they may have their family of choice. And those are people that they consider their family for many different reasons. Maybe they no longer have family because they've passed away. Maybe their family has not accepted them. And maybe they've decided that their family also includes, not only their family that they were born into or who raised them, but also, their friends and family they met along the way that are important to them. So sometimes we need to think about that broader definition and family of choice as well when we're talking to people. There we go. We also want to think about, again, the challenges that TGNQ plus populations may experience. And I keep on referencing bathroom bills because that's something that is pretty frequent, that comes up quite often. And if you want to think about it this way is, imagine, what it's like to, say, not be able to go to the bathroom in a stall and you're being stopped because it's saying a certain gender that you don't identify with. And that's a basic human right. And imagine how that is causing even more distress for you, more stress on top of what you're normally going through, just to go to something or just to use a bathroom. Different places have different laws. And for some places, they have that, all bathrooms, as an example, are open to anyone. And some people you may only find places with, gender binary, male or man, woman, male, female bathrooms. And that can be a problem. Now, we also want to understand that families may not include people who are legally married, and understanding how SOGI may impact your family of origin, like I mentioned. I mentioned earlier how we want to think about cohort differences. And when I talk about cohort differences, I'm not only talking about the impact that the word queer, that identity has on people and the different meanings, but also, how things have changed with even, research, what we know, how the culture may have changed within the places people live and how that's different from the past. And again, challenges they still experience. So we also want to recognize individuals with, different problems that may be happening, whether it be cognitive, emotional disabilities or physical or sensory disabilities, and how that experience affects their identities with the TGNQ plus communities. We also want to understand the impact of HIV and AIDS on a variety of preventative methods. Now, when we're talking about resilience, and this is kind of a word that we want to think about, sometimes I like to think about it as that bounce back or the ability to, handle things that may be stressful. And again, this doesn't mean that the problem goes away, but this is our ability to help ourselves. And, one way that we can promote resilience within LGBTQ populations as a whole is by, openly expressing and validating emotions. even sitting with someone and saying, you know what, that was a horrible experience that you had. I'm sorry that it was, that happened to you. Or when people are talking about discrimination or not being sure that it happened, letting them talk about it, exploring them with it, or exploring that with them. Also, belonging as, social creatures is really important for us. So really exploring social connections and people that may be able to validate emotions after discrimination, but also, connecting to people within, LGBTQ plus or TGNQ plus communities is really important to increase that sense of belonging, to know that you're not alone in this. And, having allies is also very important. Um, Learning or working on embracing self-worth can be really important, as well as connecting or with the supportive community, whether that be, someone who is, family of choice, family member, whether that be first engaging with, say, a support group, or, first learning to find support with even, say, a mental health provider or a provider that you trust. Maybe it's cultivating hope for the future, what the future may look like, exploring, identity development as such. Now, kind of further thinking about this for care, with economic and workplace issues, we want to understand the impact of socioeconomic status and psychological well-being, as well as understanding unique workplace issues that exist. And, really, again, when we have policies that indicate, hey, there's non-discrimination allowed here, or even policies that, or even like having diversity meetings where, other people are getting trained on like why this is important, not specific to just one population, but making it a common conversation that happens and is okay, an atmosphere of trust and openness. And this is kind of what also blends into education and training. So we want, providers to know about TGNQ plus issues and, what can be seen early on, so we can be affirmative and responsive. So people are more likely to come into our healthcare, more likely to access resources so that they can have the quality of life that they deserve. And a lot of times we can do this, one, by of course training and going to CEUs, but also, seeking consultation or maybe supervision if needed. There's a lot of journals that have come out more too that are specializing in this. And, some of that is where I've gotten some of this research, as well as, help to inform some trainings that I've done in the past as well. We also want to look at research and make sure that research represents fully and accurately what's going on for certain populations, rather than maybe blending in an entire population. We also want to think about lifespan development. So understanding that TGNQ plus individuals maybe don't want to transition, and some people do want to transition, and for other people, that's not something that is a concern of theirs at all, because it doesn't fit with their identity and how they see themselves. And, understanding that interdisciplinary approaches are important. If, the role of psychiatry, the role of PCPs, and how we communicate with other mental health providers in order to give a collaborative and informed approach to anyone's healthcare, and specifically in this conversation, TGNQ plus healthcare. Now, other healthcare strategies, one of the big things is approaching things in a non-judgmental manner. And I think that is my number one highlight for a lot of people, is when you're going through this, we want to be inclusive, using appropriate pronouns, whether they be, she, her, hers, he, his, him, they, their, them, or even things like z, zer, zers. There's different pronouns out there. They, them, their, z's, or zers are often neutral pronouns. And, using these kind of pronouns, especially they, them, their, is not something that's new. And a lot of times, people have used it to even subconsciously talk about someone without labeling their gender in the past. And we even find it now in dictionaries where there's a singular form of using they, them with pronouns when you're referring to one person. Now, that being said, we also want to think about not assuming things. I don't know everyone's organizations out there. Some organizations may have it to where, people can update their pronouns on their own, and even gender. But we don't want to assume that sex assigned in the chart or labeled in the chart is the one that is in alignment with their gender or how they identify, because there may be technological issues or update issues that may not allow that, or it may have changed. One thing that we also want to consider is documenting SOGI. I always encourage people and ask myself, is it okay to document this, and give them reasons why it may be important, and that other people could see it. That way they can provide informed consent. But one of the reasons you want to do that is so people feel like they have some control and that you're listening, and may understand what they may be going through. Because for some folk, if it's documented, they may feel like, hey, I'm afraid another provider may discriminate against me because it's, say I'm more of a conservative area, or that's happened to them before. And, that's important to identify and realize in that conversation and explore with them what their experience has been, because that may be also impacting, presenting problems, or even things like minority stress, like we discussed earlier. We also want to make sure that things like forms, materials, resources are reflecting inclusive language. And what I mean by that is using neutral language. Things like, say, for example, if we were to think about like couples therapy, if materials that we're using in a protocol are saying he, her, or husband, wife, you're falling in the gender binary with that. Whereas a neutral term or inclusive term could be partner, or a neutral term could be they, right? Or providing open-ended examples to allow individuals to relate to the therapeutic content in a personalized manner. You can imagine even seeing this kind of material, which is often still the case where it's in a gender binary, can sometimes still send across a message of not belonging or stigmatizing a relationship inadvertently, which again can compile with minority stress and may make people less likely or less willing or unwanting to proceed with things. So one thing I've already told y'all is acknowledging differences between individuals and how they may identify in various ways, and how that may be different from maybe group level information that we have. And understanding the difference between sexual orientation and gender identity is always important. And the gender expression does not necessarily mean gender identity. Someone who, say, is masculine presenting may not identify, as a man. They may identify as gender non-binary, queer, may identify as a woman. Gender expression is very different. And it's important for us to know that that is not in itself an identity. Now, we also want to understand the potential impacts of outing. And if you don't know what outing is where you have told someone else's identity and they say don't want that, or even if they're out, not considering how that may impact their future, or even relationships with others. Say maybe someone's out at work, but they didn't want, say, a client to know. We're kind of in that sense, maybe just they want to be able to go. Another kind of way of what we're thinking about with outing is, maybe not having permission to be able to talk to someone, or putting in a letter of recommendation, for example, and saying like this person identifies as transgender and has done this X, Y, and Z work. That may not be relevant information, say if that's for a job, and it's recommendation, but now we've kind of outed them, even maybe if the intent behind that comment was positive. And really, with outing, we sometimes don't know who receives that information or if they're going to receive it well, or maybe have, stigma against those identities of their own. So we also want to ascertain whether resources like shelters, hotlines are LGBTQ plus or TGNQ plus more specifically affirming when providing resources. And, I've had the personal experience where, people have told me like they got referred to, certain resources and they were not, and they experienced a lot of discrimination. And, one thing that we also have heard this with is sometimes with retirement communities. And, sometimes they don't feel welcomed. Maybe it's not by staff, maybe it's by other people that they're with. And really, this is why it's really important for us to check if they're affirming or not. And, much like I mentioned, sometimes organizations do have those symbols of affirmation or have it plainly written, and that's important to see. So we also want to consider the space of the therapy environment. Is it safe for people in TGNQ plus or LGBTQ plus communities seeking care at a VA or any other sort of health organization? Do they not want their identities to be known by others? Is it a space that they're able to be welcomed? When we're thinking about group, we may have, it's important to sometimes have those policies that are outright kind of saying like, hey, we want to respect each other's identities in this group, etc., and respect pronouns. One big thing that's coming up as well, and sometimes I've seen in research more and more, is that we also want to be aware of assessments that are normed on the binary, because that may not be as accurate. I think more recently I saw something with the MMPI and how the same person may have taken it and with different results depending on the gender that they used. So when we're asking about sexual orientation and gender identity, it's important to ask, and how we ask is also important. I think usually when I ask, I try to normalize it like as much as possible because it can be important information. And for some people, and I've heard this from other colleagues as well, they're thankful that that's happening because it's normalizing that it's important to know these things. In some studies, we found that specifically with VA, we found that 8% of clinicians reported feeling they would offend veterans, and 11% of veterans said that they would be offended. So a little bit of a gap sometimes. And honestly, I believe the more that we normalize it, the more that it is something that people expect to be asked. And there's other technological ways that we can do things, hopefully in the future, that may be helpful, like allowing people to update their gender on their own, etc. Which some people in the community may be able to do. That being said, the big takeaway is that veterans may not mind being asked about SOGI as much as clinicians may think, and sometimes it's the way that things are asked that are important. And one thing that sometimes I preface things with, this is a question that we ask everyone. If you're okay with me asking this, how do you identify with your gender identity? What was your sex assigned to you at birth? I see in the chart it was X, Y, and Z. Is that correct? Same thing with kind of sexual orientation. We ask these questions to everyone. And sometimes, if they're wanting to know why, providing a rationale as to why it can be helpful. Now, this is, I want to be mindful of time. and get through this, but I placed this here because this is a model of identity development by Lev. And one thing to kind of take away that is generally with identity development, earlier stages of identity development are associated with incongruence, which can result in anxiety, depression, feelings of panic, self-worth, or low self-worth and low self-esteem. Later stages of development are often associated with more congruence or self-acceptance and feeling of happiness. Really, we want to think about messages impacting identity development. And again, we get messages from everywhere, whether it be our family, our greater society, or the religions or spiritual practices we identify with, whether positive or negative, and that can impact our identity development quite a bit. So that being said, I did have an example for you with this but I do want to, since I'm right at the 50 mark, you can see this for yourself later, but I wanted to save time for questions as well as show you that there's resources in this presentation to include the WPATH, which is the World Professional Organization for Transgender Health, Standards of Care 7. They're working on Standards of Care 8 right now, which is important for us to know oftentimes for TGNQ populations, as well as some resources, some books that I found helpful. And this is me personally saying I found them helpful for folk that you can look at as well, some references. But I do want us to take some time for questions.
There is a question about, will you be sharing the slides? And typically we will be posting both the recording of the webinar and also the slides on our webinar page. And I'll go ahead and drop that link here in the chat. That way you can kind of keep an eye out. And typically that gets posted within the first 2 weeks or so.
Y'all are very kind. I'm reading some of the chat comments.
Yeah, I'm not seeing any other questions. So Dr. Saenz, do you have any other? Oh, actually, there's one right there. So we've got a question that asks, are there any specific resources to use when interpreting MMPIs or using other assessment measures?
That's a really good question. Not that I've seen. I saw a recent article that came out within the last 2 years about being mindful of the differences. And I've also placed in comments before that people should maybe interpret things with caution based if they are on the binary. If the measures are on the binary, not the individual, sorry. But not something specifically I know of where it's like, hey, do X, Y, and Z. I wish there was more gender diversity included in some of these things. And if I could remember the article offhand, I'm trying to think about it as I'm talking. Specific article was like 2 months ago, if not 3.
Another question is, if someone reports discrimination by a provider and is hesitant about making a complaint, how do you usually handle that after providing supportive care?
So just to be clear, this person is talking about a past provider or a current provider? Okay,
Current
so
provider.
yeah, so that's a very complex question. A lot of times when I experience that, I talk to people about, what was happening and, their rights as well as pros and cons about things and trying to empower them with that decision. Um, Most oftentimes when I've had a conversation with them, they have reported it, especially if it's caused quite a bit of harm or discrimination for them. Um, it's a little bit of a complex question, so I would need to kind of hear more, and you can always feel free to talk to me offline or outside of the presentation so I can get a little bit more information. There's also policies at different organizations, and we also want to think about ethics when we're thinking about these things as well, which makes it a little bit hard to answer directly without more information. I'm sorry if that didn't provide you as much information as you wanted, Dr. Dram, but again, happy to talk to you. Yes, there is an ethics advisor that can definitely help if you work within the VA system. Thank you for pointing that out. But I would generally recommend also consulting with folk, and I'm happy to be one of those people if you need assistance. Ethics consults are wonderful. Any other questions?
Well, not seeing any, Dr. Saenz, I'm going to go ahead and wrap us up with some announcements for those of
Okay.
you that are members or are interested in becoming members. Just as a reminder, there are a couple of emails that went out over the last week that Division 18 VA section will be awarding 2 travel awards for people interested in joining us for the APA convention in August. The deadline for those travel awards is this upcoming July 30th. We also send out a call for nominations and self-nominations for Division 18 VA sections annual awards, and those deadlines are going to be approaching here on July 27th. I also wanted to just remind our members that our quarterly VA section meeting will be held next week on July 21st at 3 p.m. Eastern Time. We're going to have Dr. Jen Smith share her leadership story with us. We will also have Ms. Conwell Smith, who is APA Senior Director of Congressional and Federal Relations for Military and Veteran Policy, joining us and telling us about some of the upcoming pieces of legislation that might be impacting your work and the services of veterans. And I also just wanted to remind you that if you will be joining us for APA's convention in August, please join us for our VA section business meeting, which will be held on August 5th, which is that Friday from 1 p.m. to 3 p.m. at the Imperial Suite, which is on the 24th floor of the Hilton Minneapolis Hotel. And if you are interested in joining us for that business meeting, feel free to reach out to us. Tell us if you'll be joining us. You can always email us at VA-Division18 at outlook.com. We are doing a little bit of a head count to make sure that we have enough provisions there to make sure that that folks are being taken care of. But again, thank you all for joining us. Dr. Saenz, again, thanks for sharing your expertise and your perspective with us. Really appreciate everything that you do, and also everything that you do to support our Division 18 VA section webinars. So hope to see you all again for future webinars. Thank you all.
Bye, all.